topics and opinions expressed in the following show are solely those of the hosts and their guests and not those of W4CY Radio, its employees, or affiliates. We make no recommendations or endorsements for radio show programs, services, or products mentioned on air or on our web. No liability, explicit or implied, shall be extended to W4CY Radio or its employees or affiliates. Any questions or comments should be directed to those show hosts. Thank you for choosing W4CY Radio.
Welcome to the Ask the Expert show on W4CY Radio and Talk4 TV, where we bring you educational information from top local experts in the fields of legal, health, financial, and home improvement. Now sit back and listen to experts in family law, association law, hearing loss, business brokers, home care, along with many other topics. Now here are your hosts, Steve-O and Sophia.
Hey, good afternoon, Houston. Welcome to another Ask the Expert show. This is so funny. We usually talk to our expert before the show about questions we're going to discuss. And for some reason, I asked our next expert, Dr. Ludwig, I said, what kind of questions are we going to talk about today? And I went back, my assistant said, why are you asking him? We've got about 25 people who wrote in when they saw the ad that the show was going to be coming on, who had a question. And I have got so many questions. In fact, Dr. Ludwig and I decided that 25 minutes wasn't long enough for this topic. And he's going to be with us the entire 50 minutes. Let me welcome Dr. James Ludwig.
Hello from Houston.
Hey, Dr. Ludwig. I can't believe it. My assistant said, what do you need questions for? Look at all the people who wrote in from the last show. And we discussed it. Your show, we did the 25 minutes and it goes by so fast. And there's so many things to discuss. So I have a list of questions that people have sent in. But first of all, tell people about Sugarland ENT and Sleep Center.
Well, I'm the only guy there that you'll see. It's a solo practice at university in 59. I had a practice for about 20 years. I did a fellowship in sleep medicine. I have 3 board certifications, 1 for head and neck surgery and 2 for sleep because they changed the governing body for sleep, so I had to do it again. But and we treat, and I treat, and my staff and I help patients with mainly obstructive sleep apnea. We do some insomnia, restless leg, periodic limb movement treatment stuff, and then we do a lot of nose treatment because a lot of nose problems either are associated with you having sleep apnea or are inhibiting you from treating your sleep apnea or complicating your treatment of sleep apnea. So it's a lot of nose, sinus, and sleep. And I've been dispensing CPAP machines for 20 years. So I know all about them, how to program them, and how to troubleshoot those devices and help patients use them. And then we also fabricate oral appliances, which is normally for dentists, but we've been doing it for a long time. And I do work with dentists, so if we have any issues. And then of course we do a lot of sleep surgeries. Whatever you need, we try to figure out a solution.
I'm not trying to scare you at all, but we have a sleep show that we do in Dallas, who went from 1 location and to now he's 8 locations, just sleep. Yeah. That's it. 8. I mean, it is a huge topic. And as you know, Dr. Ludwig, I have sleep apnea. I'm on a CPAP. I'm on a BiPAP machine. So yeah. I really had it bad, but this is such an important topic. And if you don't mind, I'm just going to go through the questions that people have sent in, if you don't mind.
Yeah, we'll do it like an office visit. How about that?
Oh, that'll be good.
Whatever walks in the door, that's what you got to work on.
Right. We're going to start off with Greg in San Antonio. He said, I just found your show last month. He said, I really enjoyed Dr. Ludwig last month as I have a snoring problem. I live in San Antonio. Does he do telemedicine?
Sure. But this is what you're going to get on telemedicine. You're going to get mainly education, because part of the evaluation is the examination. But you can get a lot of education and a lot of information on a telemedicine. But looking at your airway and those things are obviously very helpful. And a lot of people
Yes.
don't know. For example, they don't know they have nasal problems. Sometimes it's hard to know you have something you have all the time. Because to you it's just like normal until someone points out to you. I use the analogy of vision loss all the time. People, the day that you got glasses isn't the day you needed glasses. It's the day you got glasses. There was many months or years before that you weren't seeing properly, but until it gets to a point, like you can't read a menu or a screen or something on the chalkboard. I'm dating myself, chalkboard. That you realize that you're not seeing as well as you should, and that's kind of what happens with nasal obstruction and congestion. Sometimes you just are like that all the time. And so having a good exam is very important in understanding sleep airway issues, for sure.
Dr. Ludwig, I'm going to admit something on the air that I want people to understand. I think sleep disorders are very dangerous. And I'm going to tell you my reason is because I never got a good night's sleep. I would find myself falling asleep at the wheel,
Mhm.
and it just came over me. And I know since I've been on the BiPAP machine, that never happens anymore.
Mhm.
But it was really dangerous just driving a car.
Yeah. I mean, there's one of my patients I don't give names obviously, but was an anesthesiologist. And I mean, he had I'm not making this up, 90 obstructions an hour, which is, you really can't get much worse than 90
Wow.
an hour. You got to breathe at some point. And I mean, he was falling, he would do a case and then he would go to the doctor's lounge. I mean, he'd just pass out instantaneously until the next case. Imagine that you're an anesthesiologist. But you'd be surprised how many people live with untreated sleep apnea. It's pretty amazing. Like, the human body is very resilient in some ways, and then it's very fragile, in other ways. But it's amazing how much sleep apnea disease you can live with day to day and get, drudge through it. You won't do it as long as someone who doesn't have it. You won't live as long, but certainly people do suffer with it many, many years before they find a reason to get it treated, whatever that may be.
I'm going to go to Ricky and Dickinson. Do you actually stop breathing if you have sleep apnea?
Okay, so that's a good question. So sleep apnea is the better way to describe what sleep apnea is not that you stop trying to breathe, you stop moving as much or any air. So if you have obstructive as opposed to central, and they're different, obstructive sleep apnea, it means you're trying to breathe, but either you can't get enough air to meet the air demands your body requires. And for those listeners who've had a sleep study, that would be the H and the AHI, the hypopnea number. It means you're moving less than 50% of the amount of air that you should be moving, and your oxygen is dropping at least 3 or 4 percentage points during that event when you have a sleep test being done. Or you have a 90% or more obstruction, in which case that's the A and the AHI, that's an apnea. And in that case, you're not moving any air, but you're trying to move air. Your chest and your abdomen are moving, but you're kind of like a fish out of water. And the analogy I use with patients is it's kind of like when you're in a pool with a friend and your friend holds you underwater, maybe as a joke, but when you're underwater, you're not moving. And then when you finally get that, they let you, you think you're going to drown, and then they let go of you and you come out of the water and you take that big breath. That's like when you break your obstruction. And so that's why some people, when they have these events, some people, and not everyone, but they'll have these very dramatic awakenings where they feel like they're suffocating. It's because you're literally coming out of the water and you're opening your mouth because that's the biggest hole you have to get air in, and you're taking a big old breath. So a lot of people that suffer from sleep apnea don't have that, but many people do, especially the very severe patients.
We just got a person from the chat line. Do people snore because the mouth opens at night?
Well, snoring is a noise your airway makes due to high velocity airflow, because your airway is a tube. It's a muscular cartilaginous tube. Your tongue's a muscle, your palate's a muscle, the side of your throat's a muscle, the back of your throat's a muscle. The only two structures in your throat that aren't muscles are your tonsils, if you have them still, which is lymphoid tissue, and then your epiglottis, which is a piece of cartilage like your ear, the same consistency as the air. It's called fibroelastic cartilage, and that's the cartilage that folds over your voice box when you swallow so you don't aspirate. But everything else is made of muscle, and even though the tonsil and the epiglottis are not made of muscle, they're attached to things that are made of muscle. So that's why basically your throat's a muscle. And when people snore because when they're sleeping, their airway is getting narrow enough to cause a lot of resistance to flow. It doesn't mean you're not getting enough air, but you're getting a narrow airway, and you're pulling, without you knowing it, you're pulling harder to get the air you need per breath in the same amount of time. And the analogy would be like a nozzle on your hose when you wash your car. You put a nozzle on your hose because the same amount of water is coming out of your spigot, but you want it to come out faster, so you have that small hole in the nozzle, okay? And so the faster the air moves through your airway, it starts to create this high velocity airflow, creates pressure gradients, and those pressure gradients create lift, and that's why people snore. So you can snore with your mouth closed, and you can snore with your mouth open. Your mouth could be open, and you might not even be breathing through your mouth. You could do it right now. You could open your mouth, but only breathe through your nose. So mouth opening isn't a cause of snoring. Mouth opening, well, first of all, every patient that suffers from sleep apnea opens their mouth because of the explanation I gave you earlier, which is when you have an obstructive event and then you finally break that event, because eventually, you have to break the obstruction or you're not going to be here today. So when you break that event, you're going to open your mouth to breathe, and that's because that's the biggest hole you have to get air. Just like if you come out of the pool and you think you're going to drown, you don't come out of the pool and take a big breath through your nose. You come out of the pool and open your mouth and gasp for air. So, and that's why most patients with sleep apnea wake up with a dry mouth. It's not because their nose doesn't work. It's because they're mouth breathing because they're gasping for air from the obstructions.
Rachel in Northwest Houston, I found your show on iHeart. How come no one has ever done a show on sleep disorders? There's hardly any education out there. My question to you, Dr. Ludwig, is what are your feelings on the surgery to stop snoring?
Okay. Every question's like a huge topic. Snoring is not sleep apnea. So that's the first thing. And actually, that was, Steve asked me to write him in questions before the show. And I did. Well, actually, just coincidentally, one of the things I sent in today was, I get this a lot. People come in to the office. Husbands come into the office because their wives complain that they're snoring. Okay. And so the guy's only there because he wants to appease his wife and not snore, which I understand. And then we had this educational discussion about snoring as a sign of airway resistance. And then, we want to make sure you don't have sleep apnea because you probably don't know you have it if you have it. And then we do a sleep study. So let's take those two outcomes. Let's say you do a sleep study and you quote unquote don't have sleep apnea, and that in and of itself is a topic. The test says you don't have significant, how about that, clinically significant obstructive sleep apnea. So what do you do about the snoring? Well, snoring is the same problem as sleep apnea, just on a lesser degree. When you snore, you have airway resistance. So you have to either fix the resistance or you have to quiet the noise. So surgeons, ENT surgeons for decades, and you go look at all the different ways surgeons have tried to get people to stop snoring. And there's a lot of palate procedures, and usually they're office versions because people want to go to the operating room to stop snoring. First of all, it's not covered because it's considered not a medical problem, even though it is a problem.
Yeah.
So you don't want to pay for an operating room and an anesthesiologist. So there's a lot of office things that have been done, like burning the palate, laser the palate, inject 95% ethanol into the palate. And then the kind of the latest, which is still quite old, is doing something called a pillar implant, which is material. It's the same material that's used for vascular grafting when people have aneurysms and they need to have their aneurysm repaired. This is the fabric that they use to make artificial aortas and arteries out of. And we put the implants in the palate in between the two mucosal layers and the muscular layer. But the goal of all these techniques, it doesn't really matter the technique, is to try to make the palate stiffer so that it can't vibrate as well. And when you do that, you're not improving your airway. You're literally, it's like hitting the smoke detector on your fire alarm, but not putting out the fire, okay? And if your goal is just to not snore, then it's not such a bad idea, but oftentimes it doesn't give people the outcome, or it fails over time, because whenever you injure a tissue on your body, and you'll know this because I'm sure we've all been, have boo-boos and we get scars on our skin, and, over the years, those scars get softer and fader and they get lighter, and to the point where sometimes you can't even see it anymore over time. And that's because scars undergo a process called remodeling, which is where your body reabsorbs the scar tissue and lays it down again in a more geometric, laminar, organized fashion. And by doing that, it makes the scar soft. Well, if your mechanism of stopping someone from snoring was to make their palate more firm, and then you injure it and then it scars, and then over time the scar is remodeling and softening, then you can imagine that benefit that you had initially is going to go away over time, and then next thing you know, you're snoring again. So it's my belief that if you're going to treat snoring, you got to kind of treat it like sleep apnea, in that you really need to improve the airway patency and fix that problem. And it can be a throat problem, it can be a nose problem, it can be a nose and throat problem if you're really trying to get to the bottom of snoring. And then if you do a sleep study, so that's the one arm, is that your test is clinically negative. And then if you do a sleep study because you came in for snoring, you're bothering your wife, and you try and find out you have obstructive sleep apnea, and now you have a medical condition called obstructive sleep apnea, but really you're just there for snoring, then you're down the same kind of path, but it's a little different because now you can use a CPAP machine for snoring if you want to, but people don't want to even use it for sleep apnea. So they're not going to want to use it for snoring, most likely. Not that I have patients that do, but it's few and far between. So whether you have sleep apnea or you have snoring, you have a similar problem. It's just the person with sleep apnea has a bigger problem. Does that make sense?
Yeah. Oh, absolutely. I'm on Medicare. My Medicare pays for my machine. Everything goes with it. Does regular insurance cover that also?
Yeah, Medicare's can be more cumbersome because they often require you to prove, they require the person providing you the equipment to keep records that you're actually utilizing your device a certain amount of time.
Okay.
So whereas private payers like a Blue Cross or a Cigna, pretty much once they give it to you, it's yours. They don't come back and ask for data that you're actually using it and benefiting. Where Medicare, you have the document patient is using it, and I think it's 4 hours a night for half the nights, which is, it doesn't seem like that big of a bar to pass, and you're getting a benefit, and then they'll pay. But really, even Medicare, after 13 months, it's your device forever. But then, as you know, Steve, you got to get tubing and masks and things.
Yes,
exactly. And you can buy those online. You can get them on Amazon or CPAP.com or something. They're not that expensive. If you take care of them, every 6 months or something, you buy a mask. So it is covered. Yes, that's the answer. But some of them have use requirements and some don't.
Do you have your patients do their sleep study at home?
Mostly. I didn't used to, honestly. I had my own lab, and sure, is that self-serving? Of course. But yeah, but I did listen, when you have and I don't like to talk negatively on any profession, but when you do a sleep test for sleep apnea, I'm just talking obstructive sleep apnea, simple, you don't have heart failure, you're not a stroke victim or patient, you don't have Lou Gehrig's disease, you don't have a neuromuscular disorder, you don't have COPD or some other comorbidity like those, then you can do a home test. And if you're just trying to figure out, do I have it and about how bad is it? it's very acceptable to do a test at home. If you're trying to find other conditions like limb movement disorders, or, there's rare stuff like you're having a seizure while you're sleeping or things like that, then you can do an in-lab study. But honestly, Steve, the reason I really, and I hate to use the word pushed, and probably a better word is encourage, but the reason I encourage my patients to do an in-lab study is because it was my lab and I had access to the raw data, which is when you go do a test, there's an in-lab test, and you probably had an in-lab test, Steve, I'm guessing.
I had to go out for the test.
Yeah. You look like a Halloween costume. I mean, you got full EEG and you have a full EKG and you have two different types of airflow sensors.
You're hooked up everywhere.
Yeah, you got electrodes around your eyes and legs. Yes. You have belts everywhere, and so and then there's someone staring at you all night in another room. I mean, it's an ordeal, and that's why I made my lab as much of a hotel style as I could. But I'll tell you the benefit of that is that the problem with even this conversation we're having is, what is sleep apnea? And I can sit here and talk about it until I'm blue in the face, and it's still, to the average patient and even physicians who don't do it, it's a very nebulous kind of like intangible concept, because you don't see it. It's not like you touch it. It's not like you have, oh, here's cancer and here's your CAT scan, I can show it to you.
Right.
Or here's your, that's why I'm wearing a hat too. I got, some skin cancers removed. I don't want to, scare your audience. So, I mean, you can see it, touch it, feel it. There's things when you can see, touch, feel that are just more tangible. And when you're talking about a physiological phenomenon that you're doing when you're unconscious, it's just a little harder to wrap your head around it and make it tangible. So the benefit and the reason I did the home or the in-lab test is that, when you're laying in there in the bed, and all those wires are feeding into a computer, a program, and you're on the screen, you're watching airflow, and you're watching
yes,
and it's just, you see the actual real-time flow. When my patients would come in after their test to my office, I would show them I wouldn't even show them a report. I would first show them we had a black and white, infrared camera, and we would videotape them. And when you're obstructing and resolving those obstructions, you're moving around, because the way you break the obstruction is you have an arousal from your brain, your cortex, and that cortex restores muscle tone to your body. It just so happens it also restores a muscle tone to your throat. That's what the benefit is. It opens your throat. But also it restores the muscle tone to your toe and your knee and your leg and your arm, and right? So, at night, people are doing these little movements. It might just be their foot or leg or whatever. But when you fast forward that video, and then they're in the bed going like this all over the place. And that's why I think in the last show, I told your viewers to do the time release photography on their iPhone. And then when the test was positive, they would usually come back for the second test. Like you had to do the sleep with the air pressure device that, people had the poo-poo on. But then they would sleep like a freaking vampire. They wouldn't move. And I would fast forward the video and they're not moving. And I'm like, and we're not talking about some stranger that has this problem. We're talking about you. This is you in the first video. And this is you in the second video with treatment. And they just sit there and they can't believe that that's them. That's one thing when you say, oh, gee, poor Joe has blank. Oh, I feel bad for Joe, but I don't have it. So then they go about their day. You don't think about Joe the rest of the day or week or month for that matter. But when it's you, it's a lot more powerful. So I would always show patients the video, and then I would go over and show them the tracings and show them the flat line breathing, because you could squeeze the data together so you could see where the flat line. And it's scary if you're looking at you and you see flat line. People understand flat line isn't compatible with life, And then you would then again show them the same, them with an air pressure device, and show them perfectly normal breathing all night long. You get it? So because for you to be treated, I know you feel great with your machine, so you use it. And thankfully you're able to use it, and then you're able to feel good with it. Because first you have to be able to use it to feel good with it.
Yes.
Absolutely. You never can use it. You never get to that point where you feel good with it. So then you don't get the little cookie every day to use it, because you're not getting the benefit, right? And then, so you fortunately are able to use it. But so I did a lot of in-lab testing because it was extremely educational, and that's what people need to get treatment. They need education. They need to know there's a reason, and they have to be motivated. It's the same reason I didn't go into family practice, because I hate treating conditions where you don't do your part, but I do my part. and every visit's the same visit. Like, yeah,
Right.
doc,
Same.
I know I gotta
Yeah.
stop smoking. Yeah, doc, I know I need to eat less fat. Yeah, doc, I know I need to, I mean, and and there are a lot of doctors making a living like that. But surgeons like surgery because we usually like to fix stuff, you know? And I understand that people
Absolutely.
want, surgical solutions to sleep apnea. People need to understand that it can be challenging to obtain surgical cure, but not that you can't make surgical improvements, you can, but you just have to understand when people want something, I don't want the machine. I'm on board with that. I do sleep surgery, but you have to know what you're buying when you don't want that. You have to be educated.
I got to tell you, we got a question in that in 12 years of this show, I've never had anyone ask this. I guess it's a gentleman, Jackson, University City.
Mhm.
He said, "Why do we sleep?"
Yeah, that's a good
Is
question.
that a weird question? I mean,
Well, let's put it this way. They did the test. They put a rat in a cage and didn't let it sleep for 6 weeks, and you know what the rat did?
yeah,
It died, Steve. So, yeah, I mean, that's a good question. Why do we sleep? I mean, sleep's a regenerative process for our computer, right? Our brain, our body. It's um, it's interesting when when you're a child and adolescent, and one of the ways kids find out they have sleep apnea is they're not growing. And
wow,
we know that I mean, most of medicine is empirical observation. No one's guessing what the body's doing. We're measuring what it does and then trying to explain what we see. But what we know is that growth hormone is secreted during slow wave sleep. And if you're having, frequent airflow interruptions and fragmentation of your sleep, then that impedes your ability to have slow wave sleep. And so if Johnny's not having slow wave sleep or not enough slow wave sleep or half as much slow wave sleep as Johnny should have, then Johnny's not going to grow because he's not getting enough growth hormone secretion. So, I mean, there is a lot of restorative, reparative things that occur when we're sleeping. And I always tell people we don't sleep because we want to. It's funny that question because I say the same thing your patients or your listener says. We don't sleep because we want to. We sleep because we have
right,
to. Because if you're type A like me, you'd rather just be up all night and get more shit done.
yeah,
So
right, exactly.
yeah, I understand what he's saying.
And he has a follow up. He says, "What about those who tell us they only need 4 to 5 hours of sleep, and
Mhm.
they've been that way their whole lives?"
Yeah, I mean, I think there's probably a little embellishing in that number of 4 to 5, but I get the point is clearly there are short sleepers and there are long sleepers, right? There's people that need 9 to feel normal, and there's people that need 7 or 6.5 to feel normal. Um, I'll throw an actigraphy watch on one of those people that get 4 or 5 at night, and I'll see how long that actually shows to get 4 or 5 at night. But I get the point, and it's just the way we're designed. I had one of my fellow residents. I mean, we had a big problem. Well, he had it. Our our resident director got very upset with him because we covered Ben Taub, which, as you know, is or may not know, is a trauma hospital. And
Yes,
if you're trying to learn how to do surgery in your residency and you want to learn how to do the normal surgeries, which by normal I mean the ones that most patients are going to come see you for, they're not going to come see you for broken jaws and broken orbits and the gun in the knife club stuff. That's stuff that happens to the unfortunate, indigent population, homeless people and whatnot. And you get a ton of that at Ben Taub. You get a ton of trauma.
right.
And to get the trauma done, you got to do it at night. And so that you can do your thyroidectomies during the day and your tonsils and your sleep surgeries and your nasal surgeries and your sinus surgeries and all the cancer surgeries. And so as a resident, you had to put your case on for the overnight list, and then whenever your turn came up, 2 in the morning, 3 in the morning, 1 in the morning, whatever, you had to show up and do your case. And he wouldn't do it because he just felt so bad if he didn't get enough sleep, so refused to do night surgery. And then incidentally, I don't know if it's correlated, but he ended up developing type 1 diabetes during his final year of residency. So,
Wow.
we all need different amounts of sleep, and that's perfectly normal. You have to figure out what your personal sweet spot is.
We just had a caller call in and text us. Do general practitioners understand sleep apnea?
Not the way I do. Not the way a specialist does. Do they understand it better than the patient? Probably. Are they have any firsthand knowledge of sleep surgeries or really CPAP management? No. So that's why, and I hear it all the time. It's like they write a prescription for the sleep test and it comes back positive, or they send them to a lab and it comes back positive, and they write a prescription for the next test, which is a titration or the machine. And then if you have a problem, they just ask you, well, what did the DME company, which is the durable medical equipment company that gave it to you, what did they say to do? What do they recommend? Because they don't have any special knowledge of nasal problems, throat anatomy, sleep physiology. I mean, medicine's big. Medicine's become this massive, topic. That's why there's so many specialists. And I mean, even with my own field of ENT, there's, 7, 8, 9 subspecialties just for ENT. So to become really good at something, you have to see a lot of it and you have to study it over and over again, and get down in it. So there's one question I'm reading here. It says, is there a natural way to fix sleep apnea? I'm not trying to rag on you, Steve, but Steve would be to lose some weight, right?
Ah.
If you're way overweight and you have a 20-inch neck, then one natural way is to not have a 20-inch neck. But that doesn't mean Steve can look like me. I mean, you're probably a big husky guy to begin with, so you're never going to be a twig. It's like, unless you're on an island stranded, Gilligan's Island or something. So yeah, I mean, weight can play a role for some people. And I mean, sometimes maybe it's your jaw anatomy. Maybe you have a small retrognathic mandible, or maybe, you had dental issues, things like that. Those things can be corrected. And that, I would call that natural, because it's your anatomy, like your jaw is not physiologically proper for you. So weight loss can help a lot of people, but there are also a lot of people that already weigh 175, and they're 5'9" or 5'10". So are they going to lose 30 or 40 pounds? No, and so there is no non-intervention way to treat their sleep apnea.
Well, they had a follow-up question. The reason they asked was they have restless legs.
Mm-hmm.
Does that have anything to do with sleep apnea?
Restless leg is actually an awake problem. It's not a sleep problem. So when someone has restless legs, what they experience is a overwhelming urge to move their legs in the evening. It's not even when you're trying to sleep. You could be on a plane at 11 o'clock at night or watching TV, and in those diurnal hours, you have this urge. You got to move your legs, and if you move your legs, the urge goes away while you move them, and then as soon as you stop moving them, the urge returns. Now, there's a sister diagnosis to restless leg called periodic limb movement disorder, which is something that's diagnosed on a in-lab sleep study. So that's another indication for an in-lab study, and that's where you periodically move your leg, and it might just be twitching your foot or twitching your lower limb, but it's not you're wailing around. It's these little movements, and most of the time, because when we do in-lab studies, we have a full EEG. We know electrically if you're awake or asleep, so we can see if these movements are then causing arousals. Okay, but if those movements aren't actually interrupting your sleep, we don't treat it, because the treatment is a drug that you take the rest of your life, and we don't want to put you on a drug for the rest of your life if it isn't going to actually make you feel better. So no, restless leg syndrome is not sleep apnea.
This is from Joan Houston. She wants to know, I read an article about unhealthy sleep. What does that look like?
That's very broad.
Have you heard of that? Okay.
I don't know what they mean by unhealthy. Unhealthy could just mean poor sleep hygiene. I don't know what it means. I don't know what that term
James,
means.
When you drink coffee, it's supposed to keep you up. Are there prescription drugs that keep you from sleeping?
That keep you from sleeping? Well, sure.
Are there drugs that interfere with, if you've got sleep apnea? Are there drugs that you should be careful of taking? Well, it's like one of the things I have is I have high blood pressure, and I know that has a lot to do with sleep apnea.
Right. Untreated sleep apnea can raise your daytime blood pressure for sure, but it's not like going to raise it from 120 to 180. It's going to raise it like
Oh,
120 to 125 or 130 or something like that. You're not going to. I've never had a patient come to me with multi-drug resistant hypertension and then treat them for sleep apnea and they go off all their meds, but maybe their doses go down or it becomes more controllable. Sorry, my dog. Um, so yeah, but back to your question about are there any stimulant is going to make it harder for you to sleep, whether it's like a Ritalin or an Adderall, amphetamine type medication. Um, those things are
I got to tell you, since I went on the BiPAP machine, I sleep so good now. I mean, I started off with the mask, and it wasn't very comfortable. And I went to the nasal, and it's made a huge difference.
oh, you went from a full face to a nasal. Yeah.
Yes, and I got to tell you, there's people who are worried about that. I'm telling, I mean, I'm just for me, I don't even notice it anymore with the
Yeah.
nasal. It's not that big a deal. There's no noise,
Right. They're
machine
not
doesn't
loud.
make any. Right, exactly.
Yeah. I don't know if people say those things because they just, they don't really want to do it. So, and this is not a show about using CPAP, by the way, people. I'm not here to like
Right.
be like, you have sleep apnea, use a machine. That's not why I'm on why I'm doing the broadcast. I'm doing it to answer questions. But there are a lot of people who want to use or be able to use CPAP because they don't want to do the alternatives. Trust me, those people are out there. They don't want to have surgery. They don't like pain. They don't like potential complications. They don't want to do it. Okay. And then there are people that are the 100% opposite that are okay, have no problem sign up for an operation. You can tell them anything you want. They're going to go for it. And that's why there's many different treatment choices. The, the, the important thing is to understand what choices you're making, to understand what the positive and negative of each choice is so that you can determine for yourself what seems to be the best choice. Okay. And one of the things I always explain to my patients, and my wife's an oral surgeon, so I like to use this example, which is tooth pain. So, people get referred to her every day to have their teeth pulled.
Right.
Okay. That's what she does. And sometimes it's, most time it's wisdom teeth, obviously, but also it's people with diseased teeth that, and maybe that tooth had a root canal and maybe that tooth doesn't hurt. And their dentist is like, oh, you need to have that tooth pulled. And then they come in and then I'm making all this up, but let's say it's going to cost them $500 to have their tooth out and they don't want to spend $500 today. So, yeah, doc, I'm good right now. I'll come back, I'll think about it. But you really need to have that tooth out. It's really bad. It's going to give you a big problem. It's going to give you an infection or something. Like, oh yeah, I know, doc, I'll be back. And then at 2 a.m. on, Sunday, they wake up with excruciating jaw pain because their tooth infection blew up. And now her phone is going off the hook and they're willing to pay any amount of money that she wants for her to come in on, Saturday or Sunday to pull it out. And that right there just illustrates that when you're feeling bad, you tend to choose more drastic measures than when you feel good. So if I have a patient who has bad sleep apnea and feels bad, then almost anything I offer them that gives them some hope of relief, they tend to want to go do. But if you have someone like Steve who has this exact same condition but is sleeping like a baby, as he just told you, with a CPAP machine, and I offer that patient the exact same treatment options, assuming it applies to them, they're not as excited to go and do the treatment option because they already have an option that works well, that doesn't hurt them in any way. Do you know what I mean?
Exactly.
So, yeah. So, I mean, it all comes from, it's like, where are you coming from when you're having your decision? And there are a lot of healthy people that have sleep apnea that would be great surgical candidates. And some of those patients choose to have surgeries and some of them don't. It's a personal decision. But I think the decision I hate seeing is, and I see it all the time, and I just had a patient, I was just going through some patients to look up for today's, like examples of things I could talk about. But I mean, she had a sleep study like 2 or 3 years ago. And then they told her she needed a CPAP machine and then she didn't want to do it. So you know what she did? Nothing. And now she's seeing me 3 years later. And she has like terrible sleep apnea. It's really bad,
Yeah.
you know. And so she went 3 years with no treatment because she didn't want a treatment that she was offered. And that's the importance of education right there, you know.
I got a couple questions I still got to get in. Wasn't there a recall of CPAP units recently? You know
It was
anything about
actually
that?
2020. Yeah, Philips. But it was the recall was due to breakdown of insulation causing potential lung medical problems, essentially. So the FDA made them recall not just their CPAP machines, it was ventilators too. I mean, they still can't sell CPAP machines 4 years now, Philips.
Okay.
But it wasn't the actual concept of CPAP that made them recall it. It was a product in the machine for noise deadening.
Okay. Tom in Huntsville, is REM sleep the same thing as deep sleep?
No. There's
I've never heard of REM. What is REM sleep?
there's two main stages of sleep: REM and non-REM. Let me
Okay.
tell you a story about it's pretty neat actually. Sleep physiology. The sleep stages before 1950, we didn't call it sleep. It was called wake and non-wake. There was no sleep. It was wake and non-wake was the medical term. Non-wake was the medical term for sleep. And then they started watching people sleep with EEG, and Stanford was doing a lot of the narcolepsy treatments and studies, and they were doing EEG, and they were started to categorize the EEG into like they were every 30 seconds when you do a sleep test and you look at the EEG, you do it in 30-second increments. And if you look at a 30-second page of EEG, they started categorizing these pages. They look the same. It seemed like there were like 3 or 4 different looks to the pages, and that's how they came up with stage 1, stage 2, and then stage 3 and 4. And then REM sleep is the other stage. So there's non-REM, which is stage 1, 2, and now 3. It used to be stage 3 and 4. And then there's REM sleep, and REM stands for rapid eye movement sleep, and the lay term for it is dream sleep. And the way that these scientists figured out it was dream sleep is that first they figured out it was REM sleep because they watched babies sleep, and babies have very thin eyelids, and they were seeing that about half the time their eyes underneath their eyelid, they could see their eyeballs flapping back and forth really fast. So they knew there was rapid eye movement sleep going on because they could see their eyeballs visually. And that's why when you do a sleep study, they put those electrodes by your eyeball because, believe it or not, your eyeball has a magnetic pole, as a positive and negative. So as your eye moves to one electrode, it makes the little pen go up, and as your eyeball moves, the other electrode makes the pen deflect down. And then that's why you see this on the screen, and you don't have to actually watch the person sleep. You can just watch the screen and see the deflections of the needle to let you know the person has rapid eye movements. And then what they did is they got a bunch of volunteers to sleep, and then they waited for their eyes to move up and down, and then they woke them up, and they said, "What are you doing?" And they said, "We're dreaming." And so that's how we figured out that REM sleep was dream sleep. How else would we know that you're dreaming? By looking
Look at the question now that said, someone wrote, with sleep apnea, can you dream?
Yeah, you can, because that's, so sleep apnea causes sleep fragmentation. That's the pathology, okay? It's interrupting your sleep 100, 200, 300, 400, 500 times a night. Believe me or don't believe me, okay? That's what sleep apnea does. It takes your sleep and chops it up into little pieces. And that's not refreshing. And that's why you feel like crap, okay? When you're sleeping, you're still going to go through your stages. Now, does it interrupt your ability to go through stages? It can, for sure, but it doesn't have to. So some people have what's called REM-related sleep apnea. They only have sleep apnea when they're dreaming, because when we dream, not only do your eyeballs move back and forth rapidly, but you lose thermal regulation, okay? Your breathing becomes more irregular. And then every muscle in your body, except for your ocular muscles and your diaphragm, are paralyzed. You put an electrode in your thigh muscle in REM sleep, and it will be a flat line.
Wow.
Okay. And so you can imagine that if your airway is relaxed and getting smaller because it's relaxed while you're in non-REM sleep, and then you lose complete muscle tone because you're now dreaming, that tube could then collapse more because it lost tone. And then that's why you end up throwing events while you're in REM sleep only. So a lot of women actually have REM related sleep apnea. And just to finish this topic, we spend on average about 20 to 25% of our night dreaming, whether you know it or you don't.
I got to tell you, first of all, I'm blown away that not only we've spent 50 minutes talking about this, but I've got so many more questions. And the great part is you're coming back again in a couple of weeks, which we'll be announcing that. We're going to do 2 shows a month. This is such an important topic. And I cannot believe this is only your second show, and we got 25, almost 30 questions in, Dr. Ludwig. This is going to be one of our most popular shows.
Well,
and
I encourage
I'm so glad we've got you.
Thank you. Well, I want people to, informational questions, troubleshooting questions. I'll try to help you out. So if you have troubleshooting or symptoms or concerns or things you need advice on, I'm happy to.
How do they make an appointment with you, Dr. Ludwig?
We're old school, so you're going to have to either email us or contact us from my website, or you're actually going to have to talk to a human. I'm sorry. We just don't have the online option, but my website does have a contact us or request an appointment option, and then we'll call you at your convenience and get the information we need, because we want to make sure that we have what you need when you come in, so we can do a thorough job for you.
For those who are listening on radio or iHeart or Spotify, what is the phone number?
281-556-1102.
Okay. Dr. Ludwig, I am so glad we've got you, and we'll see you in a couple weeks.
Okay, thank you.
Thanks, Dr. Ludwig. It's Dr. James Ludwig, Sugar Land ENT and Sleep Center. Folks, I got to tell you, I've been doing this for like 15 years now. I've never seen so many questions come in. We have a Dallas show, specials in Dallas that we do on Tuesdays. And we've just never had this many questions. So you asked for it, we brought it to you. That will do it for us today. We'll be back with you again next week with more Ask the Experts. Thank you, Rebel.
Thanks for tuning in today to the Ask the Expert show on W4CY Radio and Talk4 TV. Tune in next week and every week to hear more from our experts on personal injury, insurance, air condition repairs, estate planning, Medicare, and many other topics in the areas of legal, health, financial, and home improvement. See you next week.